Good evening, friends. I'll be giving a very brief overview on the empirical antibiotic usage in ICU, and this is in the context of the journal that's going to be discussed between the choice with two antibiotics in sepsis. So we'll just talk about broad principles which govern the use of antibiotic use in ICU. So the topics that I would be covering is assessing the need and urgency. So the need for antibiotics and how urgently an antibiotic needs to be considered. And the second broad category that we need to be sensitized in back of our mind is the pathogen profiling. So when we sort of identify the choice of antibiotic, we need to be sort of aware of what sort of a pathogen that we may be targeting and what sort of a pathogen is what we would be having in the milieu that we are treating the patient with. And the third aspect would be selecting the right arsenal and future perspective. So it's a very brief overview on the broad principles that govern the usage of antibiotic, not into specifics of what sort of antibiotic has to be used. So when we talk about assessing the need and urgency, so obviously there are few steps involved when we consider that antibiotic has to be administered, which involves diagnostic evaluation. And one of the key aspects is obviously we do a clinical examination of the patient to determine what might be the cause of infection. And this would be sort of supported with imaging sort of a characteristics of the patient guided by the clinical examination and the lab test. So we sort of do this test. Any patient who comes with some sort of an infection, sepsis into ICU, we do clinical examination, we do some sort of an imaging, then we look into all the laboratory tests, then we integrate all this, and then we interpret it with integration and try to make some sort of a logical assessment and conclusion as to what is the choice of antibiotics that one needs to consider. And this would largely help in our decision making. So it is, I always say it is the whole art of intensive care is integrating the clinical variables, the laboratory variables, the imaging sort of a imaging sort of a findings and the monitored variables. We integrate, make an interpretation, and then make a decision with regard to the treatment. And when we are making a decision very often in ICU for treating the infection, sometimes there may have to be a good synergy between an intensivist, ID physician, and microbiology regarding the choice of antibiotics that we may make. And at this point of time, there's no single gold standard variable which is available, which can really delineate between the infectious causes and the non-infectious causes. Because when someone comes with some sort of a sepsis or a fever, as many as infectious causes may be there, that many non-infectious causes can be there. It can be any inflammatory condition in the body which is non-infectious. It can be hepatitis, it can be colitis, it can be nephritis, it can be pericarditis, all itis can be non-infectious. It can be cerebritis, so on and so forth. So there are a lot of non-infectious causes which may present as sepsis or which may mimic infection, and we may largely end up using antibiotics. And pancreatitis is a typical thing where there is inflammation, but we invariably sort of harp on giving antibiotics. So we need to be absolutely clear because it is extremely important to have some rationale in the use of antibiotics because indiscriminate usage of antibiotics has shown to increase the resistance patterns and there's no antibiotics in the new antibiotics in the pipeline. And it has been shown that 30 to 60% of the antibiotics that are used in ICU are unnecessary, inappropriate, and suboptimal. And this inappropriate usage could be due to increased or overprescription or misprescription of the antibiotics. And the epidemiological data has shown that the indiscriminate usage of antibiotics in ICU is directly proportional to the emergence and dissemination of resistant organisms in ICU. So this slide I keep showing in any infections because this forms the background of all the antibiotic stewardship that we need to adopt in rationalizing the usage. And when we look at the definition of sepsis, which says life-threatening organ dysfunction due to dysregulated host response to the infection. So if you apply this definition, so the type of clinical scenarios you get where there is a life-threatening organ dysfunction could be due to viral, and we may end up using antibiotics for this. And it may be due to SIRS, due to pancreatitis, burns, or any other itis. It can be colitis, it can be hepatitis, but we end up using antibiotics. Or it can be due to the transfusion reaction or a drug-induced reaction, which can lead to organ dysfunction. And there can be non-infectious causes of such organ dysfunction. It could be IC bleed, subarachnoid hemorrhage, or just the fact that there is a contusion in the brain. All this may lead to some sort of a surge response, or it can be just the progression of the underlying condition, considering if they have an advanced malignancy. Just the progression of this malignancy itself can present with multi-organ dysfunction, and we may call it as sepsis and through antibiotics. And most often, when we are presented with this sort of a clinical scenario where there is a organ dysfunction due to dysregulated host response, and we depend on the cultures, only 40% of the cultures are positive. And cultures many a times is looked at as only an adjunct in diagnosis, because you really miss out all these other conditions which may be mimicking the sort of a sepsis or organ dysfunction. So cultures can not be purely relied upon, because 60% of the time they remain negative. So this is the background we have, and sort of we use antibiotics for all these other reasons where there is no bacterial cause, tantamounts to medical malpractice, which we possibly are doing it day in and day out because of our inability to delineate whether it's infection or a non-infectious cause. So when we look at the sort of diagnostic conundrum or the diagnostic stewardship that we need to apply, so obviously we look at the patient, and based on the clinical examination, we need to have some elements with regards to incorporating diagnostic stewardship, which includes the right type of test we order based on the clinical findings, and the right type of patients that we recognize for doing the test, and the right timing for doing this test. So these are the three components of diagnostic stewardship, which I've covered in another video. And following this, once you determine the right test that needs to be ordered and for the right sort of a patient that you have looked at, and the right timing. So you need to incorporate certain conventional tests, which include blood culture, sputum culture, urine culture. Along with this needs to be adjuncted or complemented or synergized with rapid diagnostics to have quick answers with regards to this. This constitutes incorporation of rapid diagnostics constitutes a part of diagnostic stewardship. And once you have done this, then you have to adopt the principles of antimicrobial stewardship when we determine the choice of treatment, which basically includes 4 Ds for all the trainees. So the right sort of a drug that we identify, the right dose we identify, right duration we give the antibiotics for. Most important aspect of antimicrobial stewardship is de-escalation after we initiate on antibiotics. And so basically what I'm showing this pictorially is, so we need to adopt sound principles of diagnostic stewardship, and to just emphasize a little bit on the rapid diagnostics to be a part of the armamentarium, and adopt the principles of antimicrobial stewardship, and enhance your sort of a treatment acumen when you're dealing with the patient. So this sort of a flowchart you can remember when we are looking at any patient where we're incorporating sound principles of diagnostic stewardship and antimicrobial stewardship. And one of the important problem that we have in sort of for not able to overcome indiscriminate usage is our ability to delineate between infectious and non-infectious causes of organ dysfunction, because the signs and symptoms are very similar between the infection and non-infectious, and we end up using antibiotics. So in this situation, we would be using conventional tests, and we would be using our clinical acumen, and we would be using our rapid diagnostics, and we would be applying principles of diagnostic stewardship. But in diagnostic, there is a emphasis on using certain biomarkers like procalcitonin to try take its help as an adjunct to try to delineate between infectious and non-infectious. And procalcitonin could be considered for discontinuation of antibiotics, and this has been shown in multiple trials. So some of the landmark trial is this ProRotat trial, which showed that using procalcitonin, you can increase the antibiotic free days or curtail the use of antibiotics, which was statistically significant, and outcomes were in fact better where procalcitonin was used to guide the usage of antibiotics. And after this beautiful meta-analysis came from the Swiss group, which included 11 randomized controlled trials, 2,252 patients, where in fact they showed in the group where procalcitonin was used to rationalize antibiotics, mortality was much lesser as compared to the group where they just indiscriminately continued antibiotics that was statistically significant. And by the use of procalcitonin, the duration of antibiotics would be significantly reduced to 9.3 days versus 10 points. So basically, these two trials, and there are multiple trials which have time and again shown procalcitonin can be a useful adjunct to try and stop and de-escalate antibiotics and not to indiscriminately continue once you are reasonably ascertain that there is no obvious infection. And so this is another beautiful study which I want to cite, and this has been cited in multiple sort of antibiotic stewardships. If patient is hemodynamically, this came in Lancet Infectious in 2012, where they took the patients who were hemodynamically stable, and they showed that delayed usage of antibiotics so did not worsen mortality. And in fact, the usage of antibiotics guided by the culture showed reduction in mortality, increased the appropriateness of the usage of antibiotics, and reduced the duration. What the study basically showed is if patient is hemodynamically stable, you could wait. You don't need to jump and start antibiotics. You can wait for the cultures and be guided by the cultures to start appropriate antibiotics. This helped in reducing mortality as opposed to the group where they just started antibiotics without waiting for the cultures. And this applies to the patients who are hemodynamically stable. So by not de-escalating, there is 60% likely error in judgment. And by indiscriminately using antibiotics in 60% of the cases where there is no answer and you are unable to delineate, so you may be increasing the cost to the patient, increasing the resistance to the patient, and of course increasing mortality, which was shown in the procalcitonin studies and this Rangic study. And this would tantamount to sacrilege of gospel of 4Ds that we sort of an embrace as a part of antimicrobial stewardship. And inappropriate antibiotics, so this is again just a revision. So inappropriate usage of antibiotics is directly proportional to the emergence, and we end up using antibiotics for all this. And there are two good RCTs which showed beneficial effects of de-escalation. Once you have a bug, you need to de-escalate the antibiotics to the narrow spectrum and target it to that bug that has been identified. And meta-analysis also showed it's in non-inferior. And two large procalcitonin studies justifies its utility as an adjunct to de-escalate. So de-escalation is the way to go in adopting sound principles of antimicrobial stewardship. So when you talk about assessing the need and urgency, when there is no sepsis and you have done the diagnostic test, so just you don't need to start antibiotic. Just do uh, vigilant watch and keep waiting and wait and see how patient progresses. But if there is a sepsis patient, you know there is life-threatening organ dysfunction, but there is no shock. So you can adopt conventional tests along with rapid diagnostics and start antibiotics within 3 hours. Wait for the cultures and be guided whether you have to de-escalate or whether you are dealing with non-infectious causes. But if patient has septic shock, then obviously you wouldn't wait for any diagnostic test. So you would embark on giving antibiotics as soon as possible, and preferably within 1 hour. So basically, so your antibiotic sort of an urgency is decided by the severity of the clinical conditions. If there is shock, obviously we wouldn't wait. If there is sepsis and no shock, adopt rapid diagnostics and wait and see if you have any answers, and you could possibly give antibiotics within 3 hours. And most importantly, when we are embarking on use of antibiotics, one should have some sort of a clinical sort of a sensibility in recognizing what is the possible source, whether it is the CNS source. If the source is CNS, obviously you have to do test to recognize with lumbar puncture whether to confirm CSF, or if someone has a long-standing IV line or a central line or a firm cath or dialysis catheter, one needs to look at that as a source. And if the lung is the problem, look at sending BAL, sputum culture, so on and so forth. So try to at least have some sort of a inkling on the source of the possible infection. And if it is abdominal, see if there are any drains and those fluids to be sent or any imaging to be done to identify the abdominal source. And if it is urine source, obviously you would be sending for urine culture. So basically, this picture is denoting when you are thinking of organ dysfunction or an infection, you should have some sort of a ability to try to look at possible source in that patient to rationalize the choice of antibiotic. And then there's something called pathogen profiling, and this pathogen profiling would be determined by the source of the infection that your clinical examination has reflected upon. So your clinical examination should give you cues as to what the possible source of infection is, and that is pathogen profiling. And this has to be taken into the context of underlying comorbidities that the patient may have and the prevailing antibiogram. So each center may have certain prevailing bugs which are more common, and the type of resistance patterns are hugely variable with regards to different institutes and different sort of a geographical region someone may be working on. So having antibiogram, having some inkling of the type of bugs that are prevailing in your center is influences the choice of antibiotics. And one needs to look at post risk factors or the patient risk factors that may put them at a high risk of developing MDR infections. So all this constitutes pathogen profiling. So you need to have inkling as to what may be the source. You need to have inkling about the sort of antibiogram, and you need to have inkling about the patient's comorbidities and whether he is at a risk of developing MDR infections. And this constitutes sort of pathogen profiling. And one needs to have some sort of an idea whether there is any colonizers in the patients which would point out to the possible type of infection that patient may have had. Or one should very importantly look at any previous hospitalization within 90 days. If patient is hospitalized for at least more than 5 days, then it would constitute as healthcare associated infections. And these are the patients who are at a risk of MDR infections. And most important, the third aspect is to look whether patient has received any broad spectrum antibiotics in the recent past. So all these factors, which are shown pictorially, will determine the type of pathogen that you may be dealing with and the type of antibiotic you would be picking up to treat these patients. And when it comes to selecting the right arsenal, once you have pathogen profiling based on the possible source and based on the comorbidities and whether there is any risk of having MDR infections and the antibiogram, so one need to look at your own hospital or institutional guidelines to determine the choice of antibiotics. And the choice of antibiotics should possibly involve the spectrum initially, which covers the broad spectrum, the gram positive, gram negative, and anaerobes. And then obviously you would de-escalate once you get the culture reports, you would de-escalate to target whatever organisms that you have identified. And one should not use combination if there is a known susceptibility that has been recognized for a organism, or whether if the organism is identified, one needs to target that organism, and one should not use combination to enhance the clearance of that antibiotic with a hypothetical thought process that it would enhance the organism more effectively. And combination should not be used where there is a low risk of multi-drug resistant organisms. And when you are selecting the right arsenal, it is also important to keep the pharmacokinetic and pharmacodynamic properties of the drug that you are administering, ensure that adequate drug concentrations are maintained and the drug that you're administering has less side effects. And one has to do the precise dosing, and one has to determine the administration because some of the drugs are given as stat. Like if you look at aminoglycosides, it's given as single bolus dose. And if you look at a cephalosporins or carbapenems, they need to be given as continuous infusions for a long period of time to achieve good area under curve concentration. And dosing frequency also is important because when you deal with aminoglycosides, they're given as once a day, but when you're dealing with cephalosporins or carbapenems, they're given in a spaced frequency. So these are some things which need to be adopted and followed to optimize the PK/PD. And wherever possible, if therapeutic drug monitoring of the drug could be done, that is the ideal way of optimizing the drug delivery. Like there is therapeutic drug monitoring available for aminoglycosides, vancomycin. So it is desirable and advisable that therapeutic drug monitoring is used for optimizing the usage of antibiotic. So just the last slide on future perspectives. So this is a broad overview as to what are the principles that we need to adopt when we are selecting empirical antibiotic. The future perspective is one needs to have some sort of a decision tree to identify the type of patient that we are dealing with and characterize the patient with regards to all sort of a comorbid patients, which puts him at a risk for developing MDR infection. So which means this patient may be immunosuppressed, he could be elderly patient, neutropenic patient, or end-stage organ disease, which could be end-stage lung disease, end-stage liver disease, end-stage kidney disease needing dialysis, or it may be severe septic shock, or who's had a transplant, or who's had underlying malignancy. All this will sort of characterize the patient as to who is at a risk for developing MDR infections. And most importantly, look at whether patient is immunosuppressed and try to look at the type of colonizers patient may have had, whether he's been recently admitted for more than 5 days in last 90 days, and any recent recipient of any broad spectrum antibiotics. So this typically characterizes the type of patients or profiling of the patients who is at a risk of developing MDR infections. And most importantly, have an antibiogram, local antibiogram, to try to understand the prevailing bugs and the type of resistance patterns that may be prevailing in your hospital. And the future is try to have a AI algorithms to try and put all this information and guide the clinician as to the type of antibiotics that one has to use. And AI also would possibly hold promise in trying to determine the timelines as to when the antibiotics has to be used, when it has to be stopped, or when it should not be used, when it could be deferred. All these are some of the future sort of a dimensions that can evolve. And even AI could be helpful in determining whether a combination antibiotic should be used or a single antibiotic should be used. And most importantly, all these factors to be considered to minimize our ecological impact of over usage of antibiotics on the patient and on the institutional sort of a resistance patterns and on the global impact. So this is where we are heading at. So AI holds promise in trying to integrate, because humanly it may not be very easy to integrate the patient characteristics, the comorbid characteristics, and the risk profiling of the patient, and the antibiogram to sort of determine, and the type of antibiotics, their cross reactivity, and the combinations, synergy, so on and so forth. So AI possibly has a role to play in future. So this is a brief overview, just as a context setting for the journal that will be discussed, because this journal would be talking about empirical choice between piperacillin, tazobactam, and cefepime. So these are some of the broad principles one needs to bear in mind before considering. So thank you very much. So I'll have over to Anirban to take over the discussion.